Hello and welcome to the UNAIDS Asia Pacific launch of the 2024 Global AIDS Update. My name is Cedrian Martin. I'm the UNAIDS Regional Communications Advisor. We're so happy that you could join us. The report, The Urgency of Now, AIDS at a Crossroads, was launched globally at the AIDS conference in Munich on Monday. This is our opportunity as Asia Pacific stakeholders to do a deep dive into the new data for our epidemics and our response, and also to have a discussion with people from the worlds of community, academia, government, to find out what's going well, what we're doing right, but also what do we need to do better? Where do we need to change course in order to end AIDS as a public health threat by 2030? A few items of housekeeping. We have interpretation available in Khmer, Nepalese, and in Thai. And also, if you have any questions, please feel free to leave them in the chat. After the panel discussion, we're going to field as many of your questions as possible. So as the questions occur to you, please just drop them in the chat and we'll get to as many as we can. We're going to start with a presentation from Eamonn Murphy, Regional Director of UNAIDS Asia Pacific and Eastern Europe, Central Asia. He's joining us from Munich.
Good morning, Cedrian. Good morning, colleagues. It's great to be with you. It's a powerful conference this year. As you've heard, some great innovations that will help us. We need to be looking at what's happening in our region. And we have just launched this week the new report, as Cedrian said, The Urgency of Now, AIDS at a Crossroads. It reminds us that the world has a choice, as do we here in Asia and the Pacific. We can act now to end AIDS as a public health threat by 2030, which means by the end of this decade, we need to keep people living with HIV healthy and to slow new infections to a trickle. Over time, AIDS-related deaths should become obsolete. And as fewer people are infected, the cost of HIV treatment will steadily fall. Or we can continue doing what we're doing now, implementing some best practices, but not others. Spending money. Sorry, someone needs to mute, I think. Spending money, but not always in the right areas and amounts. Prioritizing treatment, but not prevention and human rights. But where would that take us? It will mean higher and higher costs to expanding epidemics that affect different groups of people in our countries, and possibly to yet another existential threat to our societies and economies in some of the countries. The 2025 Global AIDS Strategy targets are ambitious, but they are not wishful thinking. We know this because 9 countries have already achieved the testing and treatment targets. 4 countries from Asia Pacific are treating more than 80% of people living with HIV. Cambodia, Nepal, New Zealand, and Thailand. Nepal is also among the 4 countries globally that have reduced new infections by more than 75% and can potentially reach the 90% target by 2030. They're well on the way. Others could learn from their approaches. 18 countries and territories have eliminated mother-to-child transmission, including 4 in our region: Malaysia, Maldives, Sri Lanka, and Thailand. One of the key approaches of the Global AIDS Strategy is U equals U. Undetectable equals untransmissible. This means that when a person living with HIV takes their medicine so the level of virus in their blood is undetectable, there is zero, and I repeat, there is zero chance that they can transmit the virus. That's a game changer in so many ways for people's lives, for our communities, for our countries. The lower the viral load, the lower the chance of transmission. The report contains evidence which further proves this. The graph to the left shows the global distribution of people living with HIV. Green represents people on treatment who have an undetectable viral load, significant proportion. Yellow are those on treatment who are yet to achieve viral suppression. Pink are people who are on treatment but have not yet gotten yellow are those on treatment who are achieving viral suppression. But pink is for those who have not yet achieved viral suppression. And red refers to those who are diagnosed but not on treatment. And the darker red represents people who are not yet diagnosed. The bar on the right shows the risk of sexual transmission. As you can see, most transmissions occur with people who do not know they are living with HIV. But there are also significant transmissions amongst those who are diagnosed but not on treatment, and those who are on treatment but have not yet achieved viral suppression. This is why we have a moral and a public health imperative to help people learn their status, provide testing, start them on treatment right away if they are positive, and to ensure that the treatment works completely and they're able to access treatment throughout their lives. Then we'll see U equals U in reality for many more people, and this will have a significant impact on the direction of the epidemic in our countries and regions. In light of what's happening and what's possible, Asia and the Pacific are seriously underperforming. In 2023, 78% of people living with HIV were aware of their status. That means almost a quarter, though, of people living with HIV don't know their status. And as we've just seen, their chance of transmitting the virus is highest. 67% of people living with HIV were on treatment last year. 65% of all people living with HIV had achieved viral suppression in our region. So roughly 1/3 of the people living with HIV in our region are not getting the care they need and the support they need to stay healthy and to prevent HIV in others. Asia Pacific has the world's largest HIV epidemic outside East and Southern Africa. In 2023, there were 6.7 million people living with HIV in the region. To achieve the global prevention target, Asia Pacific, with its huge populations, will be absolutely critical. But we must lift the game. We must do more and do it faster. AIDS at a crossroads. Which pathway are we taking? This region accounts for a quarter of new infections in the world last year, 23%. In 2023, there were 300,000 new infections in our region. But progress has stalled. As the bottom graph here shows, since 2010, there has just been a 13% reduction in new infections for the region as a whole, far lower than the global average decline of 39% seen in the top graph, and starting to get further away from that each year as we report. We are not getting closer to the epidemic control if every year a significant number of people newly acquire HIV, requiring lifetime treatment. There were 150,000 deaths due to AIDS in our region last year. Since 2010, AIDS-related deaths in Asia Pacific have declined by half, but are still far too high. Both new infections and deaths in 2024 estimates show no significant change between 2022 and 2023. This is a serious warning sign that momentum has been lost and that more has to be done to serve the people that our prevention and treatment services are not yet reaching. But perhaps the issue is that the percentages don't drive the point home clearly for us. This is the reality. Every 2 minutes there is a new infection in our region. In the short time that I've been speaking with you, 3 more people contracted HIV. Every hour, 35 people contract the virus, including 9 young people. Every day, more than 300 men who have sex with men, 80 people who inject drugs, 50 sex workers, and 15 transgendered people get infected with HIV. Every hour, 17 people die due to an AIDS-related illness. 17 people every hour. And every day we lose 9 young people between the ages of 15 and 24. These are all avoidable, as we know. So now let's look at what's happened on a country-by-country basis since 2010. The graph to the top shows new infection trends by countries, the countries that are providing reports. There are growing epidemics in Bangladesh, in Laos PDR, in Papua New Guinea, in Afghanistan, Fiji, and the Philippines. The increases in Bangladesh and Afghanistan look small in terms of percentages, but are more significant in terms of absolute numbers. When we look at mortality trends on the bottom graph, we see that all 6 of the countries with rising infections also have growing death rates. But AIDS-related deaths are also increasing in Mongolia, in Indonesia, and in Pakistan. In 2022, in Asia-Pacific, 4 of every 5 new infections, 79%, were among key populations and their sexual partners. Most of these cases were in gay and other men who have sex with men, with 43%. And this is the population with the most growth in the epidemic. According to this report, across the region, new infections increased by 32% among men who have sex with men since 2010. 1 of 5 new infections are in the remaining population. That's people who are not from the key population communities, or they're people who are having sex with people from these communities. As some countries' epidemics mature, we're also seeing the emergence of more mixed epidemics, meaning both key populations and other members of the wider population are significantly impacted. The transmission patterns between and even within countries are distinct, and I'll speak to that in more detail about what's happening in these countries. In the Philippines, it has Asia-Pacific's fastest growing epidemic and one of the fastest in the world. There were 6 times more new infections last year than there were in 2010. That's primarily epidemic among men who have sex with men, and particularly young MSM. New infections in PG have increased also by 241% since 2010, and there are indications that these new infections are partly driven by an uptick in intravenous drug use. And the spike in new infections is particularly since COVID. In Papua New Guinea, new infections have doubled since 2010. While key populations remain highly vulnerable, there is now a need for attention to other groups. Every day in Papua New Guinea, 5 infants are infected with HIV. The fundamentals of designing an HIV response remain true. We must first understand the dynamics of the epidemic in each and every country before we can craft our interventions. And often we need to understand the dynamics that are different from our urban and our rural areas across our countries and apply different approaches. A key element of these dynamics in Asia Pacific is related to young people between the ages of 15 and 24, and particularly young key populations. As the bottom graph shows, around 1/3 of new infections in Vietnam, half in Myanmar, Indonesia, Philippines, Thailand, Cambodia, and Laos PDR are among young people. To the top left, you see we have rising new infections among young people in some countries, particularly Papua New Guinea, Afghanistan, and the Philippines. And HIV prevalence amongst young people who have sex with men has at least doubled in Malaysia, in Indonesia, and in Vietnam. Access to combination HIV prevention and treatment services among key populations remains limited, unfortunately, across many countries. Data from reporting countries show that just about half of sex workers now access targeted prevention services. About 1/3 of men who have sex with men and transgendered people in reporting countries are receiving services. Access is even lower for people who inject drugs at 21%. And yet in our region, we require most of the world's opioid agonist therapy interventions. Yet most countries have very low coverage. The median is just 9% coverage. We're hearing here at the conference about the great opportunity of long-acting injectables, both for treatment and for prevention. Pre-exposure prophylaxis, or PrEP, are HIV's drugs that prevent people from contracting the virus if exposed. We have them available in our region, and we'll have new formulations and this long-acting injectables available soon. Not as soon as we'd like it, but they will be there. But we're not seeing the uptake. PrEP has the potential to markedly lower new infections, but Asia Pacific needs to pick up the pace, transitioning from pilot projects, which are not needed today, to national rollout. We would not see the we will definitely not see the expected payoff from investment in PrEP unless it's implemented to scale. We also hope these new innovations of long-acting will make it easier for some people to access PrEP who don't have to explain why they need a pill a day or why they're doing different things. They can do it much more effectively with this new approach. We have a mixed picture where some countries are accelerating progress, others have some significant plans for expansion, and yet while others' rollouts haven't yet got any national traction, they're far too small and localized. There's a huge gap of 98% to reach the 2025 PrEP target. There were just 204,000 PrEP users in this region last year, far short of the 8.2 million target. When we come to treatment coverage, again, there are wide variations, as you can see in this graph. Several Asia-Pacific countries are not even reaching half of the estimated people living with HIV for treatment. These include Bangladesh, Indonesia, Islamic Republic of Iran, Mongolia, and the Philippines. 3 countries treated less than 30% of people living with HIV in 2023 in Afghanistan, in Pakistan, and Fiji. The majority of Asia-Pacific countries are, though, somewhere in the middle, between 50 and 80% treatment coverage. But they also need to increase their pace. It is now that we need to see this action to have an impact on the epidemic and on people's lives. Every gap to the treatment target represents our risk of losing more lives and increasing new infections in our region. We were at the forefront of the response decades ago. We have stagnated and are going backwards in terms of the response. So which pathway are the countries taking? In this slide, the blue bars show the proportion of people living with HIV who know their status and are on treatment. The grey segments represent people who are diagnosed but not on antiretroviral therapy. As we learned at the start of my presentation, this dynamic also fuels HIV transmission. Around 1/3 of diagnosed people living with HIV in the Philippines, in Malaysia and Pakistan, half in Fiji and 2/3 in Afghanistan are not on treatment. To the other extreme, we see that it is possible to ensure that almost all people who test positive are linked to care and receive antiretroviral therapy. Cambodia, Bhutan, New Zealand, China, Japan and Thailand are all treating more than 90% of diagnosed people. A great success. Very different countries, very different health systems. So there's no excuse to say it can't be done in any of our countries. So why is it that even where treatment services are available, people get diagnosed and then disappear into the shadows? This brings us to the social and structural factors that drive people away from HIV services. There are legal barriers to the HIV response across the region. We talk about this every year. We see some progress, but not anywhere near enough. 38 countries criminalize some aspect of sex work, 17 criminalize same-sex relations, and 28 criminalize drug possession. 20 countries criminalize HIV transmission still, exposure or non-disclosure, while 14 restrict entry, stay, or residence of people living with HIV. This is an irrelevancy in today's world with the treatments that are available and the prevention services that should be in place. It's the countries that need to show the leadership on this and not seek to criminalize or penalize the people. For people from key population communities and those living with HIV, these are real reasons to remain fearful and hidden. And this is why we're seeing rising infections and increasing deaths in some of the countries. There is an interplay between these laws and the societal attitudes that manifest as what we refer to as the stigma and discrimination. This directly undermines health and well-being. This slide shares select findings from Stigma Index 2.0 reports and behavioural surveys. These are just examples. We see that 38% of men who have sex with men in Yangon, Myanmar, avoided accessing healthcare due to stigma and discrimination. In Thailand, with a very progressive and open response to HIV, yet a quarter of young people living with HIV reported HIV-related discrimination in health settings, while 59% of people living with HIV in Iran said they experienced stigma and discrimination in the community. Violence also remains a factor for HIV. 14% of sex workers in Cambodia reported experiencing physical or sexual violence in the last 12 months. Almost 3/4 of women who use drugs in Malaysia do not get the reproductive health care they need due to stigma and discrimination. And in Vietnam, less than 5% of people living with HIV seeks redress when their rights are violated. This is another reason why our countries need to work on campaigns around U equals U to explode the myth that HIV automatically equals death. This whole message about being on treatment, achieving viral suppression means zero transmission can change the dynamics and address community stigma. Over the last decade, external funding for HIV programs in our region have decreased by 60%, while domestic resources increased by a significant 47%. The report tells us that 12 of the 17 countries analysed rely on international sources for more than 50% of their prevention financing. This is a serious problem if we're looking at sustainability. The region's high donor dependency for prevention may be a looming crisis for us. We know that the global economic situation is affecting financing for health programs widespread, and that's impacting on HIV. So while we applaud the increased domestic allocations, most of that money is going to treatment and commodities. At the same time, we are seeing dramatic reductions in international funding for prevention and the enabling environment work that's so critical. More resource mobilization is needed, especially as the report projects that the number of people living with HIV in our region will more than double by 2050. So we must quickly address both the investment gap in the region when it comes to spending on key population prevention, not just the available overall resources, but where is it allocated? Where is it used to have the biggest impact? This graph shows that in 9 of the countries with available data, out of total HIV expenditure, they are spending less than 15% on key population programs. So we need governments to invest in more prevention for the right groups in the right places. And with the new tools, it's much, much cheaper and much, much more effective, while at the same time mobilizing to express concern about the inadequate donor support. We need collective action by countries in programs like the Global Fund for AIDS, TB, and malaria to make sure the needs of HIV in this region are not forgotten. How do we hold on to foreign investments where possible, keeping them strategic and focused? There is clear guidance on how more of that money should be invested. The Global AIDS Strategy calls for 30% of testing services, 80% of prevention services, and 60% of societal enabler programs to be delivered by community-led organizations. Their programs are much cheaper and much more effective than many of the programs that our governments implement. But as the bottom graph shows, in Asia Pacific, most countries don't have policies that enable community and key population-led organizations to be registered and provide the services. So they can contract private companies, but the system is not allowing them to contract those who could be most effective, these community organizations themselves. The common theme of this story is inequalities across the board of what I've discussed this morning. Inequalities between countries, inequalities of key populations, and even inequalities between the key populations. Think back to the different levels of service access for people who inject drugs in our region. To address disparities in access to healthcare, HIV services and funding, we must confront these disparities. And I do not refer only to service delivery. I mean the very strategies needed to address the disparities in socioeconomics, in the political and legal systems that leave entire countries and communities behind. I also refer to the different economic outputs and resource needs within our region. Not all countries are the same. The impact of COVID is still being felt. Which countries' gains can be threatened by sudden reductions in international investments? We need to prioritize and advocate globally. and which countries are overdue for significant and deliberate donor support to address the tragedy of inadequate service access. For our region, UNAIDS has 4 broad priorities. The first, to renew and intensify the focus on key populations, to ensure that we are reaching the right groups in the right locations with the right interventions and at scale, not like PrEP today. Modernize service delivery, make full use of the prevention, the diagnostic and the treatment tools that we have at our disposal. We are so advanced in the type of programs and the diagnostic tools and treatment available, but they're not being implemented at the scale we need. This includes PrEP, the self-testing, community-based testing, harm reduction, and U=U. To eliminate barriers to equitable program coverage, this will entail reforming laws and policies that are hampering access to services for key populations. Some countries are even looking at bringing in new laws that will make this worse. This is the wrong time to go backwards. It's also about education and dialogue necessary to build more accepting and safe societies, not just for people at risk of HIV, but for many others in our societies. We must do more on this. Finally, we must mobilize sustainable financing for the HIV response, and sustainable means political leadership, the right programmatic mix, and the resources needing to make effective impact in each and every one of our countries. It also means investing more in prevention and community-led models for the service delivery. Not only do we have the means to end AIDS, we have a winning strategy, but what's missing is consistent political commitment. If we do not act now, the promise of ending AIDS by 2030 will slip away, and we need to get countries and communities back on track and on the right path. Thank you very much. Looking forward to the discussion and the inputs of our very distinguished panelists to come. Thank you very much.
Thank you so much, Eamonn. Wonderful examples of success in terms of prevention strategy, treatment strategy from within our region, but also very clearly the numbers tell a story of people being left behind, communities being left behind, and countries being left behind. Let's go now to Harry Prabowo for a response from civil society. And Harry is wearing his 7 Alliance hat today, but he's also project manager for APN+. Harry, over to you.
Thank you, Cedrian. Thank you for giving me the opportunity to speak on behalf of civil society. Today, I'm honored to bring forward the voices and perspective of our communities, especially those living with and affected by HIV and AIDS. We are at a critical juncture in our fight against HIV/AIDS. As of now, there are 6.7 million people living with HIV in our regions. Despite the progress we have made, there are still 300,000 new infections and 150,000 AIDS-related deaths each year. While we've seen a 13% decrease in new infection and remarkable 51% decrease in AIDS-related death since 2010, our work is far from over. Our community faces significant challenges in accessing testing, treatment, and care. The testing and treatment cascade stand at 78, 67, and 65, highlighting gaps that need urgent attention. In some countries, the epidemic is growing at an alarming rate. Afghanistan, Bangladesh, Fiji, Laos, Papua New Guinea, and the Philippines are experiencing a rise in new infection. And many of these countries, antiviral therapy ART coverage remain below 50%. This lack of coverage is particularly concerning of Afghanistan, Bangladesh, Fiji, Indonesia, Iran, Mongolia, Pakistan, and the Philippines. Additionally, the majority of mother-to-child transmission occur in Indonesia, India, Papua New Guinea, with 26%, 23%, and 8% of cases respectively. One of the most alarming trends is the 32% increase in new infections among men who have sex with men, or MSM, since 2010. This indicates that key populations are not receiving the target intervention they urgently need. Moreover, there is a 64% resource gap to meet the 2025 target. The shortfall in funding is a stark reminder that we must not become complacent. We need sustained and increased investment to ensure that no one is left behind in this fight. As representative of civil society, we are calling for renewed commitment to ending the HIV/AIDS epidemic. This includes scaling up access to testing and treatment services, especially in countries with low ART coverage, implementing target intervention for key population, including MSM, to reverse the trend of increasing infection, ensuring comprehensive and sustained funding to close the resource gap and meet our 2025 target. And last one, strengthening community-led response and empower those most affected by HIV to take leadership roles in the fight against the epidemic. Together, we can make a difference. Let us stand united in our commitment to end HIV/AIDS and ensure a healthy future for all. Thank you. Go back to you, Cedrine.
Thank you so much, Harry, and thanks for emphasizing the importance of community leadership to connect with the people that we need to connect services to. Let's now go on to Cecilia Oh. She's the UNDP Global Program Advisor, and she will give a response on behalf of UNAIDS co-sponsors. Cecilia.
Thank you so much, Cedrian. A very good day to everyone. I'm very pleased to be speaking on behalf of UNDP as one of the 11 sponsors of UNAIDS. Let me just start by saying that I think the title of the UNAIDS report is very good. You know, our HIV response is indeed at crossroads. We are at a crucial point in the evolution of our global HIV. I'm not going to go into the details because Praphan has already done, but just to say that in our region, there is both progress and setbacks in HIV. On the one hand, we've seen since 2010 decreases in new infections and AIDS-related deaths. But on the other hand, I think both Eamonn and Harry have looked at we're seeing great pandemics in a number of countries, Afghanistan, Bangladesh, Fiji, and so on. And we know that the ART coverage is below 50% in many of these countries. And I think what we also want to know is, you know, the fact that these epidemics are taking place in the context of a region that is experiencing both prevalence and disruption. And since I'm speaking on behalf of UNDP, I want to draw attention to the overarching development landscape in the region. Because we know that whatever HIV response we adopt, it cannot take place in isolation. So what do we need to know about the development landscape of this region? I'm going to refer to the 2024 Regional Human Development Report, Asia Pacific. Now, the IHRI for short identified 3 trends. That the Asia Pacific region has seen long-term progress, but that this progress has taken place in the context of both persistent disparity as well as widespread disruption. And we know, you know, I don't need to give you too many examples of disparity and disruption, but we've seen this in the sense that the COVID-19 pandemic, conflict, and climate risk pose great disruption to the access to services. Now, the IHRI 2024 paints a picture of this turbulence and uncertainty, but we know that we're progressing too slowly on it. And we also know that at this current trajectory, the 2030 goals will be achieved only by 2022. We know human insecurity has heightened and that the development landscape in the region continues to shift. It is clear that we need new approaches to development. And we also know that we need growth. Growth remains a necessary underpinning for human development and for the generation of the resources that we need to fund HIV and AIDS programs. But I think what is clear for us too is that we need the right kind of growth and development, which has equity as an underpinning. Because we need to address the persistent disparities and prevent further disruption that we see in the region. Now, I think both the UNAIDS report and the IHRI both point to a similar theme, which is that we are at a crossroads, both in terms of our development approaches as well as HIV. And I think this is the time to meet, make sure that we make the right decisions and the right decisions to invest in ensuring a response that's both enduring and sustainable. On the positive side, I think we know what we need to do. Both Eamonn and Harry have already alluded to this, but I think there are 3 things that we want to keep in mind. The first is that we need to address stigma and discrimination. And we do this by addressing the legal and societal barriers. This includes implementing the legal protections of unfair and discriminatory laws and policies and HIV-related liability. We've seen recent success, for example, in the Philippines, on the signing of the implementing rules and regulations for the city's anti-discrimination ordinance. Now, this strengthens protections for individuals of diverse sexual orientation, gender identity, and expression against various forms of discrimination. UNDP has supported the passing of this law, which was also supported by community-led groups. For example, the Praphan project Cecilia Oh. Now, the second thing we need to do, as is already clear, we need to empower communities. The role of communities in the HIV response. We know that community-led responses are essential, but they are underfunded. We know that the donor funding, needs to be sustained. We need to have greater mobilization, as Eamonn has pointed out. And communities need to be empowered because strong community engagement can improve the prevention and treatment services. In this context, UNDP is working with different partners, including Thapa, in terms of trying to scale up population-led approaches to counter discriminatory and punitive laws and policies. The partnership that we have tries to look at three approaches to counter the discriminatory laws and policies by identifying what works, by building, scaling, and amplifying, and most importantly, by investing in key populations. And we hope that this initiative will strengthen key population leadership, capabilities, and partnerships so that communities are able to provide the leadership for the global HIV response. And then I think, it's been said already, but do need to see sustainable financing for long-term progress in terms of our HIV. And on long-term progress, I think we need to see improved access to treatment. Eamonn has talked about the innovations that we're seeing and that we should have access to. We need to have enhanced awareness and education, and as well as strengthened health infrastructure. And importantly, we need to see policy and legal reforms, as we said before, to support the people living with HIV. I think these are the three crucial elements that are needed for an effective, enduring, and sustainable HIV response in the Asia and Pacific region. And so let me just stop here by also just congratulating UNAIDS as well as the communities with which our organizations work with for having led, some of the successful HIV responses, but we know that there is more to do. Thank you.
Thanks so much, Cecilia, and thanks for the reminder that this is such an interwoven, interconnected challenge, not just about HIV, but about health systems, about access to justice, about law reform. So much work to do, and so important that all our stakeholders work together to get it done. We're going to go now to our very esteemed panel. We're excited to invite Dr. Phalla. He is the National AIDS Authority Deputy Director from Cambodia. Professor Phanuphak. He is the IHRI Senior Research and Policy Advocacy Advisor in Thailand. Welcome, Professor, but also a longtime stalwart clinician, researcher in the AIDS response. And we welcome Sara Magar from the National Network of Women Living with HIV in Nepal. And Sara wears lots of hats with ICWAP, with Yankee population work. So we're going to draw on her rich expertise. And we also welcome Cathy Ketepa. She is the chair of the Key Population Advocacy Consortium in Papua New Guinea. Her video is not working, but the most important thing is that her voice is here. So we'll be hearing from Cathy. We're going to start with Dr. Phalla. Cambodia, as we've seen just now, has made such incredible progress toward achieving the 95 testing and treatment targets. but you face some challenges as the country transitions to a higher income classification in a few years. So can you tell me what's being done to ensure the financial sustainability of the response once that happens?
Okay, good afternoon from Cambodia. I think for securing the financial sustainability for HIV response is very, very important for us to reach the target and also to sustain the response. So let me show you that right now, is at the 31% of the its expenditure. It raised from 24% in 2017 to 31% in 2023. Okay, so the national budget contribution also, increase with the allocation of the budget to provinces from 10,000 to 20,000 of the 25 provinces. Also, with the, starting from the Phanuphak city provinces, right now we are encouraging the integration of HIV/AIDS in the commune Songkat. Up to now, we have more than 200 commune having the money for HIV/AIDS response. Okay, on social protection, up to now we have 52% of the people living with AIDS, the health equity fund. And then with the commitment of Royal Government of Cambodia, we are now expanding the social protection to cover the key population, based on the vulnerability of their job. Okay, back to the sustainability, we have developed the sustainability roadmap. I think we started the process since 2018. Up to now, we have the review sustainability roadmap, and sustainability roadmap already been included in the national strategic plan and also the national policy for ending AIDS and sustaining HIV/AIDS response. So this is the way we not only addressing the financial gap, but also strengthening the addressing the 5 tenets of the sustainability. So knowing that we have the problem of the young people, back to the chart presented by, we have a little money on the for prevention. I think we now developing the FFP, and then we will use the efficiency support to address the gap on prevention. And besides also, the sustainability working group will, link the epidemiology data, the program data, the political commitment, the human resource, the human right, the financial, and the structure to address the of HIV response, so that we can own the response, have better, use the data to allocate our effort for precision of public health. So thank you very much.
Thank you so much, Dr. Phalla. And you could see that there's such a comprehensive response and so much planning and forethought in terms of how you can track resources, how you can use evidence to plan for the future, to steadily take more financial responsibility for the response, and to figure out how we're going to be able to sustain it into the long term. We go now to Professor Praphan. Thailand, we've seen excellent results from Thailand as well. You were there at the beginning of the epidemic, diagnosing the very first case. Could you give a sense of what have been the key decisions that have accelerated Thailand's HIV response and brought it to this point?
Greeting from Thailand. After being in the HIV business for 40 years, I have to say Thailand has many useful or important policy decisions. For example, elimination of mother-to-child transmission, free HIV testing for everyone every year in order to reach early diagnosis. And also ART for everyone at any CD4 level, especially on the same day of HIV diagnosis. And also free PrEP for everyone at risk. So these are the good policies that are generated from the scientific evidence worldwide. Sometimes it's also from WHO recommendation, and many times also from the local evidence done by the Thai Red Cross AIDS Research Center or by IHRI. For example, the same-day ART and also the key population-led health services. The policy makers, the politicians, even they say they have this policy, it doesn't mean that it's a political commitment or genuine political commitment. Sometimes they may just surrender to the evidence. Sometimes they may not believe that totally. You know? Especially when the policy makers, political leaders, some of them are very genuine, they are very good in terms of implementing it, but not everyone. Especially when policy makers and politicians change so often in Thailand, the newcomers may not have good understanding or good belief on those policy makers. So they may change it, they may revert it finally. This is the main reason that even Thailand is at the best situation in the region to end AIDS. But I don't think that AIDS can be ended on time. Many field workers, they are very eager to do the good things here, but there's no driving force. There's no one look after them that this will be done in a large scale. The program managers may think that our politicians, our ministers of health may not have interest at all. So they just wait until the new policy makers come, the new program manager comes. So this is the problem with Thailand, even if we have good policy decisions.
Thanks so much. And you make an excellent point. It's not just about having the programs in place, and it's not just about financial sustainability. It's also about political sustainability. And that's part of what we have to discuss and strategize around. How do we ensure that from one administration to another, our policymakers are aware and they're empowered and they understand the issues, and we're guiding them to do the right thing. Sara, let's go over to you now. We've heard about Nepal's success, both in terms of treatment coverage, but also critically in terms of reducing new infections. Can you give us some insight in terms of what has been done differently in Nepal to achieve, I believe it's 79% decline in new infections since 2010?
Hi everyone, good morning from Munich. I am Sara Thapa Magar and I'm representing National Federation of Women Living with HIV and AIDS. And I'm also working with ICWAP, which is a regional network that works for women living with HIV in Asia Pacific. So talking about Nepal, I think, thank you everyone for giving this opportunity to share our good practices and what we are doing in Nepal. And before I start, I would like to give this credit to our community members, those who are working day to night to reach to this goal. I think we have a different program that specifically targets from different communities that is specifically designed for certain communities, let's say for FSW, MSM, migrant workers. And talking about, let's say it's also about the U equal to U, that is the reason that we have success to reach this goal. And also we are working with the communities, and I think one of the reasons that we have reached this is our program is community-led and by and for communities. And I think until and unless we don't strengthen our community members, we don't educate them, so we won't be able to reach. The one of the thing is community-led activities in our country. Another thing is targeted intervention for different key populations, including PLHIV. We also have a very good response in U equal to U PrEP, and also 100% testing for a pregnant woman. I think these are the activities that led to reach the current goal.
Fantastic. And again, we hear about the importance of community leadership in order to reach communities. So important. Cathy, question to you. Could you give a community perspective on what must be done to change the tide on new infections in Papua New Guinea?
Thank you very much. My name is Cathy Ketepa. I'm the chairlady for the Key Population Advocacy Consortium, and I also coordinate the sex workers organization in Papua New Guinea called Friends Frangipani. I'm going to talk to you about what we want for the epidemic in Papua New Guinea. It is all about urgent action needed to address HIV epidemic in Papua New Guinea. The rising tide of HIV infections in Papua New Guinea demands our immediate action. As the chairlady of the Key Population Advocacy Consortium and the coordinator for Friends Frangipani, the sex workers organization, our community organization deeply committed into public health. I urgently call upon our nation to take decisive step to curb this epidemic, which is the key population at risk, they're all at risk, inclusive of sex workers, among the most vulnerable, face very, very high risks. We must prioritize their well-being by ensuring access to prevention, testing, and treatment services. Their health is intrinsically linked to the well-being of their entire society. There is an alarming trend. Annual new HIV infection have surged from 3,300 in 2010 to 6,700 in 2023. More than 100% increase. It's really increasing. This tragedy is alarming and threatens the fabric of our communities. Compliance is not the motion. And we also have the pregnant women and vertical transmission. Despite increased diagnosis among pregnant women, testing rates remain unacceptably below. They're very, very low. Only 23% of estimated pregnant women were tested for HIV in 2023. Vertical transmission continues to affect newborns, with 30% born with HIV. We must do better now in the country. Bridging the treatment gap. The ART for prevention of parent-to-child transmission remains inadequate. Only 58% of mothers living with HIV receive ART. We must bring this gap to protect the health and future of our children. Crossing.
So we lost connection to Cathy. Hopefully she'll be able to reconnect soon.
Sorry.
Okay, Cathy, yes?
Yes. Thank you.
Yes.
Thank you so much. The crossing 1% prevalence mark for the first time since 2010, HIV prevalence in Papua New Guinea has exceeded 1% of the adult population 15 years and older by 2022. This milestone underscores the urgency of our response, and we cannot falter now. So the Papua New Guinea's path forward, our call to action. Our strategy must be multifaceted: comprehensive prevention, strengthen prevention efforts through community-based outreach, education, enriched condom availability and accessibility. Expand the PrEP to more than 2 provinces and promote community-led screening, tests as well as HIV self-testing. We need to empower the community to lead and provide prevention services. Accessible testing and treatment. Expand HIV testing services that's to include, especially among pregnant women. Early diagnosis is very critical. And we need to ensure timely access to ART and support reduction of loss to treatment. No one is to be left behind. We need to sustain funding. We need to secure sustainable funding. We call upon our government, international partners, and philanthropic organizations to invest in our response to the HIV epidemic in Papua New Guinea. We need to support the key population community members. The key population community members are the frontline leaders because they know best how to fight the disease. The exhausted leaders need to be humbled, and they need to exalt the communities because we are now in the urgency of AIDS at the crossroads to end HIV in 2030. So we need to choose the path to public health, but not the criminalization of people's human rights. It is accessibility and respect the human rights for sex workers, gay men, MSM, and transgender to have some constitutions that will guarantee the constitutional laws that are against the decriminalization of sex work and the Sodomy Act, and make some fair decisions. So in the words of Friends Principality and Key Population Advocacy, we are calling for us to be together and we can turn the tide. Let us unite, advocate, and act. Our nation's health depends on it. Thank you so much for hearing, and this is all from me. Over to you. Thank you.
Thank you so much, Cathy. And that was comprehensive. The need for the focus on key population issues, absolutely. And also she mentioned what's happening in the antenatal clinics, the need to ensure that all women have access to testing and to treatment. So a comprehensive response required in Papua New Guinea and in many of the other countries, very well articulated there. So in the second line of questions, we want to focus a bit on the how. How do we advance these agendas? And Dr. Phalla, I'd like to go to you first to ask about how we secure government commitment. Can you tell a bit about the Cambodia story? How was this very robust commitment from the government of Cambodia achieved?
Okay, for this question regarding the political commitment, I think right now with the effort of the government, with the Prime Minister all inside of the national policy for ending and sustainability. Right now, we admit that HIV/AIDS is not over in Cambodia, and the young people are become infected, and new infection has been plateau over 7 years, something like that. And then, these kind of things, worrisome for the Cambodia, because from now to 2030, it's estimate that 8,000 people will become infected if we continue to have such infection rate of 1,200 every year. And most importantly, 40%, more than 40%, which is 3,000 people, you know, like will be affected. And then the most important thing for is like we need to convince line ministry, sub-provincial level to be, you know, like aware about the scenario of not having, you know, enough support for drug, especially when the old people living with AIDS, you know, pass away, replacing by young, a bunch of young people who need treatment after 30. Then I think the what you call the honeymoon of the, you know, generic drug be secure, and then this costs a lot. And that's why, you know, like we need to convince people about the front-loading investment. In this regard, I think in March 15, the council minister with the, you know, like support of our prime minister, we developed, we issue the national policy indicators and sustaining the HIV/AIDS program, and we call open line ministry institution, both at national and subnational level, to work hard to fulfill their respective duty to coordinate, to monitor, to evaluate HIV/AIDS response. So the national policy also, you know, like put the, what we can find in the position of having a role to secure resources for HIV program, for you know, like effective program, and also efficient use resource as well. And in this regard, I think we are committed to move from 31% of total expenditure to 50 from 2023 to 50% of overall expenditure by 2028. And also the national policy, I think we have been, you know, with the Excellency Chair, Senior Minister Chair of National Aid Authority, we have sensitized line ministry, provincial level to prioritize activity, develop their plan, and then mobilize the resource, you know, like, you know, implement those plan. And then at the end of every year, I think line ministry will be accountable for the result in front of the council minister. I think this is very, very important. And more importantly, as Eamonn, as the regional director said earlier, I think we have a little, you know, like funding for the prevention. I think in this regard, the sustainability roadmap working group will, you know, address the issue of social contracting. I think lest we admit that, you know, it's not spending, it's investment for the future. And then I think we can convince the line ministry to, you know, like to front load investment and, you know, contribute to social contracting for having the support to address the young people need, especially the young Americans. I think right now the situation is more complex when young people right now involved in also in the drug use. I think become sexualized drug user and also much difficult to address it. And then in this regard, policy commitment also need to address the stigma, discrimination, and especially the so-called you know, like gender identity, to allow us to work closely with the population, especially the young people, to tackle the problem of reducing 1,200 down to 200 by 2030. So thank you very much.
Thank you so much. And again, we hear this very systematic approach, gathering the evidence, making the case for front-loading investments, and really a lot of advanced planning. So a great model there from Cambodia. Professor Praphan, with respect to community leadership in the AIDS response, delivering services, how was the AIDS response, AIDS stakeholders in Thailand, how were they able to successfully advocate for that approach by the government? Please unmute, Professor. Yeah, Professor, please unmute.
To deliver
Great.
the HIV services is a very new idea. And sometimes it's very difficult to implement because it's a kind of overstepping the roles of the medical doctors, laboratory technicians, pharmacists, for example. So what we do in Thailand is try to demonstrate that this concept we call it key population-led health services, KPLHS, works effectively. At the same time, we have to remove all the barriers from those medical council, medical technology councils to make them understand and don't object the work. So this project was started in 2014 with the support from PEPFAR and USAID. We selected key population organizations in 4 provinces that work with the key populations. We train them and equip them with the instruments that they can do HIV testing, CD4 cell testing, and also deliver PrEP and ART according to the doctor's order. This is working together with the local public health officers and hospitals to make sure that the quality is good enough. When this kind of evidence is generated, we then submitted it to the Ministry of Public Health. Fortunately, at that time, the minister is a professor in the medical school, so he understood the concept very well, and then legalized it, agreed that well-trained key populations can do the work in parallel with the health officers in order to deliver certain important HIV services. And this legalization makes this concept being financed by the Thai government. However, this kind of success has intermittent interruptions due to the misinterpretations and misunderstanding of the effort. Especially now with our Asian context, that we always think that health has to be delivered by healthcare workers, so-called paternalism and also hierarchical aspect of health system makes it unequal power between doctors and other providers. So this has to be, I think, more definitely or firmly pinned down or nailed down, that this is an important thing that is being accepted worldwide, and it should be expanded widely in the country.
Excellent. And great point about allies with decision makers who are sensitive and who could pull the levers of power to get things done, but then we have to sustain the education, sustain the advocacy from one administration to another. Sara, same question to you. How were you able to advocate successfully for community leadership in delivering services in Nepal?
So I think it's the same answer from my side as well. But let me give you a little bit different perspective from my country. I think the advocacy is not limited within the national level, but also with the community level. In Nepal, what we do is we have a very good coordinations and collaboration with the community-based organization and national network. Whatever the issue that we get, we raise that in national level. And we have a very good engagement with our government bodies. And we are very lucky, we would say lucky, and also not only the lucky, but also a very long history of doing this coordination and collaboration with government and stakeholder. So our government is positive towards us. So we are very strongly engaged with our policymakers and governments, and they are very helpful. And also, I think it is also by the support of the different donors that we have different programs that allow us to engage with our government people and policymakers. And another thing is partnership and collaboration and coalitions with the national networks. We do have a different coalitions advocacy group within the network that allows to have good coordination and advocacy keep going with the government. And another thing is that's the one of the positive things from my country. I will give you the example that is community-led monitoring in Nepal. So whatever the issues come, we are trying our best to give services to our community members. So I think the community-led monitoring is one of the best example how we are doing advocacy in our country. So the issue, whatever it's come, they are trying to solve by themselves. And but at the same time, national network are trying to help with the coordination and advocacy with the government. So it's more like not only the coordination and advocacy of national networks with the government, but also it's the engagement of community-based organization with national network and also with the local government and also in the national government. So that's how the communities we are working in Nepal. Thank you.
Great, and a wonderful example of the value of the capacity building to implement CLM and to execute services at that level. We see that translated at the country level as you work with national government and with local government as well. We have just about 15 minutes for questions. So let's shift to question and answer right now. And if you have any questions, please do leave them in the chat. We have one for Harry from Ellie Faisal, a journalist with the Jakarta Post. Ellie says she's spoken with several NGOs who are concerned about HIV prevention and care in Indonesia. And they say that people living with HIV in some areas of Indonesia are still facing difficulties accessing treatment. Is that correct? And what do you think are the most pressing issues on HIV prevention and care for Indonesia? You've been given the Indonesia hat.
Now I'm gonna put my Indonesian hat. So okay, so I think yes, this is true. I mean, like we still have a lot of challenge despite there is so many progress, especially in the urban area where people, where government already roll out the SUFA, which is like test and treat campaign a few years back. So whenever you know the positive despite your viral CD4 count, then you can straight away on treatment. But this seems like not apply to certain area in Indonesia, particularly when we're talking about decentralization. Decentralization sometimes give a benefit and also the unbenefit of the situation, because the authority usually come from the district or the provincial level and how they want to do the policy provided by the national center. But again, this becomes still a challenge. In terms of prevention, similarly, I mean, for example, prevention, we're talking about PrEP. PrEP in Indonesia has been conducting a few piloting, I think, but like Eamonn said, I think this is not time for the piloting anymore. It's time to scale. So I think what we have to encourage for the Indonesian government is to start to scale the last mile just here. I mean, like the ending achievement by just around the corner. So we have to be ready. And I'm follow what Professor Phanuphak said. The Indonesia start to thinking about KPLHSF, key population and health system strengthening. I think we need a lot of community to start able to deliver the service delivery directly to their communities. That's all from me, Sir John.
Great. And question to you, Eamonn. Countries like Indonesia and several others you spoke about that have relatively low treatment coverage. Can you give some guidance about what can be done now? How do we summon not just the programmatic components, but also the resources to ensure that they have the scale-up required in a short period of time?
Thanks very much for the question. Of course, as I said, it depends country by country. So it's hard to give a general response to that. But countries need to invest in their treatment programs directly. Countries should be able to already access through the Global Fund resources for treatment, but we need to see the investment in the local services. Just as Harry was saying with the example of Indonesia, where Indonesia is a middle-income country, it can afford to provide treatments. It needs to look at the costing of those treatments. Where is it sourcing them? How to make it cheaper? Some countries are challenged when they reach middle-income status, and then it triggers a different costing threshold. And so we saw that in Malaysia, where one of the challenges for Malaysia is to get the price of treatment down. And for some small countries, this will be the same for prevention. We may need to look at some kind of pooled procurement so that they can make advantage of pricing, because as we see more countries moving to that middle income threshold, it doesn't mean the health services or education services are well resourced at the time of transition. It takes a while after that, because many of the economic decisions are focused on how to increase the growth in the economy. But there are a number of different things. So we'd have to work with country by country. But the most important thing is that political commitment. It's the leadership. Regardless of successive governments, we need to see that change happen. And that will mean the programs can be put in place. And it's different in the Philippines to Fiji, but all governments can do more. COVID did have an impact on health budgets, but we're past COVID. We need governments to reprioritize the funding to their health programs, including to HIV, and look where possible for the integration with primary health care, which can make it cheaper, but also look at how to source the cheapest commodities, but move straight to the most effective of the treatments at the same time. Back to you, Cedrian. Thanks.
Thank you. And we have a question. I think I'll ask Sara and then Cathy, specifically about women showing up for HIV testing and learning about U equals U. Can you tell me a bit about what your experiences have been?
I think that's a good question, by the way, because right now we are not really focusing on women, because as we can see, even I'm here in the conference, and most of I feel like the women living with HIV are not prioritized, and talking about women accessing, talking about U equal to U in my country is a different scenario, because see, nowhere in every platform, like women living with HIV are not prioritized, because we don't think women living with HIV are something that needs to be talked, because women are inside the house and they are not threat to anyone. So it's more like, okay, like let's say women are not that important. But thank you for raising this question. Let's say women accessing U equal to U or any information, we are not targeting specifically for the women's. Most of the target audience are other communities people, or let's say women are put it backward. That's what I feel. But with the information, with the for the U equal to U, it's like I feel like for the U equal to U. Sorry, can you please repeat the question? I just black out from the question. Sorry.
Well, the question is to share your experiences about women coming forward for HIV testing and also education about U equals U.
Oh, okay. For the HIV testing, it's really hard in my country because of the perceptions toward HIV. Because in my countries, talking about sex is more like culturally and religion. In terms of religion, it's not open about talking. Especially for the woman, it's not really that open. And for the information, they're available for everyone. But obviously, being women, they are not that in position to access this information. And let's say U equal to U is for everyone in my country, like for the information, but we need to target especially for the women living with HIV. That's what I feel.
Yeah. And Cathy, can you tell us the experience in Papua New Guinea about women accessing testing and also engaging with this information, the promise of U equals U? How has that gone?
Thank you. Thank you so much for the next question. especially in Papua New Guinea. We all know that it's a very, very low income country, but most likely that the community members, the key population community members came together and we formed the Consortium. And under the Consortium, we have 7 alliances where we are made up of the sex workers, men with diverse sexuality, the transgender community, PLHIV, and so forth. So for us, our main aim is to advocate for the community members to access the services, and U equals U, we normally work really very closely with the partners like IHRI 360, UNAIDS, that they really encourage the community members, and especially the female sex workers are really taking the lead to advocate for the services that are provided for them. So most of the female sex workers are really accessing the U equals U, and they're also accessing the clinics that are provided for them to access and have HIV testing. And now in the country, we are now introducing PrEP. And now as of next month, we will be looking into the DRV, which we are now partnering with Think Place, which French Frangipani and Key Population Advocacy will take the lead to do a result in 2 provinces and city and the Western Islands where the HIV rate is very, very high. So I, as the chair lady for the Consortium, I will be taking the lead. So I'll be working very, very closely especially in the Highlands region. The information is not very well delivered, so we're really trying our very best to engage with the partners, to work closely with the PHAs, which is the good role that we are now taking the lead to do the community-led monitoring. And it's like a baby for the Consortium, so we're trying to extend to the other parts of the country and advocating around the U equals U, though it is not well disseminated into the remotest areas because Papua New Guinea is very diverse and the information is not very well delivered. So it is now the Key Population Advocacy Consortium is taking the lead to do all this, and we very much really appreciate what UNAIDS does for us, because they always make sure that we receive the message and then again we deliver to the unreached communities. So we are really very much happy to have a Consortium, and the Consortium is really doing a lot for the key population data. There are somewhere yet to be reached. So we're still working around that area, and we are really looking into sustaining and holding on to the community-led monitoring the program that we are running, and it's like a baby to us, so we won't let it go. And this is all from me. Thank you.
Thanks, Cathy. So again, emphasizing the work that the KP Consortium is doing to get the word out about U equals U. But as she mentioned before, we also have a huge challenge in terms of antenatal care and ensuring all pregnant women know their status, are offered tests and are offered treatment. A question here about MSM and sexualized drug use. And Professor Praphan, could you give us some insight, if you have any? We've already seen that 43% of the new infections are among men who have sex with men. What do we know about how we respond to chemsex, or the sexualized use of drugs, with this community?
I'm not very good on that yet,
Yes.
but we do know that MSM and transgender women, they have quite common chemsex together. So how to prevent the harm from having chemsex, at the same time they still enjoy sex? This is a very important thing here. Dr. Nitya, my daughter is doing that. I'm not in a good position to answer this. Why as I'm on the microphone, I would like to ask Eamonn, because I agree with him that political commitment is most important thing here. But how to do that?
Thanks, Dr. Praphan. And I had the pleasure of being at the global launch with the other Dr. Praphan, Dr. Nitya Phanuphak, Dr. Nitya Phanuphak. And she also talked about the importance of these issues, not just for Thailand, but for the region. There's a combination of issues here, and we need more understanding around the whole issue of sexualized drug use, how best to respond to it. The methamphetamine use, that is a big factor in the epidemic in Fiji, the new numbers in the last couple of years, significant growth. Now, how do we deal with that? When we're dealing with the opioid use of opioids, we've got methadone, buprenorphine, there are treatments available. But for methamphetamines, it's a different situation. Some people are only using them very sporadically, and it's a very controlled use. There are others who become dependent. So it's a very different mix. So we're working with UNODC, but importantly, it's the community leadership itself. And IHRI and a range of partners across the region are organizing a conference later this year. And I don't mean a conference where we just got people coming in and talking. This is about strategizing. And UNAIDS is partnering with them on this because when we talk to countries in ASEAN and other parts, the need is recognized. They can see the impact on the rising MSM numbers and amongst others, like Fiji, it's not MSM. This is a general community use of methamphetamines. So we need different approaches, and it's going to have to be tailored. But the rise in MSM infections is partly because we've seen more success in other groups. It's that political decision on where do you prioritize? Which communities are you willing to work with? And in some places, we've seen better success in other communities. So it puts the percentage proportion for MSM higher. But at the same time, we have new generation epidemics. Think of the Philippines. This is principally young MSM under the age of 25 and young transgender, a whole different epidemic. And so the issue is the old epidemic was responding to a different population group and their needs, whilst not recognizing necessarily, and certainly not fast enough, the needs of the young MSM. And as we've seen, and you'll find in the report, this is a challenge for a number of countries that have had success in many other parts, but now young people coming through are being left out or not reached. And that's also part of the need to change the model of our programming to more how do we reach these populations? And they're very different to the old populations and approaches. So the virtual space, the online, rather than the fixed site, people don't want to go in. How do we get around the stigma and discrimination? I've just seen while we're in the launch now that the report is coming out about the 6-month injectable for women, right? And this is going to your point, Sara. How do we help women? Women in all their diversity, be they drug users, sex workers, the spouses. How do we help them? Think about 6-month injection for sex workers as a prevention tool. For serodiscordant couples, it makes it much easier than the risk of having to take pills every day. So again, PrEP, we have new tools coming online. We need government's collective action to push the drug companies to get the prices down, get them to the people who most need it in our countries in the region fast. Considering the number of people who are becoming infected in our region is not coming down, and the volume, the numbers, the sheer numbers of people in our region. Cedric, back to you. I hope we did justice to the question. Thank you, Dr. Praphan.
Thanks so much, Eamonn. So we're just about ready to wrap up. I want to say a hearty thank you to all our panelists, Eamonn, Cecilia, Harry, Dr. Praphan, Dr. Tia, Sara, Cathy, much appreciated. And just a reminder to all our HIV response stakeholders that we have a winning global AIDS strategy. We just need to make sure that we hold policymakers to account, that they keep the promises and work to meet the targets that are in that strategy. I'll encourage you to go to aidsdatahub.org UNAIDS.org, where you can get all the regional data, and also to UNAIDS.AP.org, where you'll be able to find this presentation a little later on, and other resources about the HIV response for Asia and the Pacific. We're going to sign off for now. Thank you so much for joining us.